Hi, welcome. We're going to start with the second half of the scenario of the opioid crisis, and we'll be showing interoperability between healthcare and public health systems to support the reporting to public health. So, surveillance for diseases and conditions is a core public health function. Reporting of these conditions by healthcare providers is required by law in all U.S. states and territories. Currently, this reporting occurs manually, which means a provider has to identify that their patient has a condition of interest to public health. They have to understand the reporting requirements for the jurisdictions in which might be appropriate for where they either deliver care or where the patient lives. And then they have to send a case report to public health either by fax or filling out a paper form and sending it in. And this just really doesn't happen very often. There are over 200 reportable conditions in most U.S. States and territories, and that makes that burden quite heavy. So we're working on automating this process, which we call electronic case reporting. That's the automated generation and transmission of case reports from electronic health records to public health for review and action. That allows us to pull information that's provided in electronic health records for use for this purpose. In this demonstration, you'll see we use a shared infrastructure to facilitate the interoperability. And in this diagram, you can see the different components that we'll walk through in the demonstration, starting with care being documented in the EHR. This allows the provider to do their normal workflow in caring for patients, but behind the scenes in a case report, if it matches a trigger code that are codes of interest to public health, like a diagnosis code, a laboratory order, a laboratory result, a case report can be generated and sent to this shared infrastructure where there's a decision support service that can look at the reporting requirements across jurisdiction and determine if that case report is of interest to public health, and then provide that to the appropriate public health agency. This also gives us an opportunity to return information to providers that might be relevant in the context of that patient. Tell them that it was a case of interest to public health, where it was sent to, provide information like treatment guidelines or infection control guidelines. Would also give us an opportunity, if necessary, to ask additional questions that might be specific to the condition that that patient has. So you'll see that in the electronic health record as well, and that information going over to the public health departments allows public health to start the any case investigation that would be necessary. So now I'm going to pass it off to Dr. Masood, who works in the EPIC EHR, and will show how he is providing care to Stella in this case.
All right, thank you. We're going to begin this part of the demonstration with a recap of the clinical care that Stella has received while in the hospital today. You can see that she came in with symptoms including respiratory distress, confusion or an altered mental state, meiosis or pupil constriction, and all of these led to diagnosis of an opioid overdose. Now you can see here in her chart that there is an accompanying ICD-10 code with the opioid overdose diagnosis. This is important, as Laura just said a moment ago, because it allows us to begin the process of automated case reporting rather than have providers do it manually. So this kicks off some functionality in the background of the EHR that occurs within the flow of care. And here we're going to be simulating it with the click of a button. So the message is sent downstream via one of EPIC's standard interfaces, and at this point, it's going to be sent off to the public health agencies of interest.
As mentioned, when the problem list was entered into EPIC's EHR, it triggered the ICD-10 code to be sent for the process to be sent to public health. But that process is a preliminary process of which cases out of millions of cases in the EHR are of interest to public health. So a more comprehensive evaluation is needed to confirm whether the case is reportable and to which public health agency or agencies. This is done by the Reportable Conditions Knowledge Management System, or RCKMS. RCKMS is a decision support service and knowledge management system that holds reporting logic for all public health jurisdictions and all reportable conditions across the country. In our scenario, RCKMS is hosted on the HIMSS platform, which is a secure-based platform. And you'll see HIMSS in just a moment, but HIMSS receives the EICR from EHR and calls for the RCKMS Decision Support Service. RCKMS then processes the EICR to determine whether it is a reportable condition. RCKMS first looks at which jurisdictions the ECR will go to. It looks at the patient address and sees that the patient is in Calhoun County, Washington, and where the care was provided, which was in Nashville, Tennessee. Because these two addresses are different, RCKMS will run the rules for both jurisdictions. RCKMS then looks at the rules for Washington's logic. It compares the EICR, which contains the problem list, against Washington's logic and finds that it is a match. As you can see, the problem list for the ICD-10 code is a match. RCKMS checks that Calhoun County wants the reports based upon the patient's address and confirms that it is a reportable event of opioid overdose to Calhoun County, Washington. At the same time, RCKMS repeats the process for Tennessee and it also finds a match against the Tennessee's reporting logic. RCKMS confirms that Tennessee wants reports based upon the facility's address and confirms that this is a reportable event of opioid overdose to Tennessee. So RCKMS outputs both of those decisions, routing details, and additional information into a single XML that HIMSS will include in the reportability response that will be sent back to the provider. The EICR and the RR will also be sent to Calhoun County, Washington's HIE, which is Care Evolution, and will also be sent to Tennessee directly. So with that, we're turning it over to HIMSS to show you more about routing.
So HIMSS is where the interoperability happens. This platform will have connectivity with hospitals and public health departments through networks like Direct Trust, eHealth Exchange, and state HIEs, and it'll support a variety of transport protocols. Since this all happens behind the scenes, on the screen in the middle here, what we're showing is the HIMSS dashboard. This is actually showing the message that was sent by Epic being processed by the system through RCKMS and out to the public health agencies. On my screen to the right here, what we're showing is a high-level view of the process so that you can follow along. So for this demonstration, HIMSS is directly connected to Epic using IHE XDR. It's connected to the Tennessee Department of Health using XDR, and it's connected to Care Evolution, which is the Washington State Department of Health's HIE using FinMS. So the first thing we do when we receive an EICR is we validate it for structure and necessary data elements. If there are any issues with the EICR, we create a reportability response, or RR for short, with all the errors in it and send it back to the sender so that they can fix it. All the valid and confirmed EICRs go to RCKMS for decision support, which is what Therese just walked us through. It's the output from RCKMS that tells HIMSS what to include in the reportability response and where to send the EICR and reportability response to. So we'll see how the providers use the RR in just a minute. The RR also includes information that can be helpful to EHR administrators, such as errors and warnings and other machine processable data. But once we have created the RR, we send a copy of it back to the sender. Now this happens whether or not the EICR is reportable, so they receive it 100% of the time. If the EICR is reportable, we send the EICR and a duplicate copy of the RR to all the jurisdictions that it should go to. So in this case, it can be more than one, both Tennessee and Washington. So for this use case, HIMSS and RCKMS provides a set of centralized resources that allows providers and health departments to be able to efficiently exchange data. Duplicating these across all the connection points would be very difficult and redundant. So now I'm going to pass it back to Epic so we can see what the RR looks like from the provider side.
All right, thank you. Here I am back in Stella's chart. And what we'd like to do is, as we have said, allow providers to continue to do the things that they need to do for public health reporting using the tools they use every day rather than having to use more manual workflows. So from Stella's chart, I'm just a click away from my in-basket function where I do a lot of my everyday patient care. And I can go ahead and click into my outside messages section here. And we have a message about Stella. There's a lot of content in this message from both Washington State and Tennessee, but my primary function right now is to click the link here and answer some supplemental questions that are required as part of reporting. So these questions load up here. I'm going to go ahead and answer them based on my care experience with Stella. Right down the line, I do believe this was an overdose event. The drug of overdose was unprescribed opiates. Based on our interactions during care, we learned that her use history was approximately 9 months. She does have an interest in reducing or stopping her drug use. She will be attending a medication-assisted treatment program, and she will be discharged with naloxone. Now, this is not necessarily a common workflow, but we are demonstrating it here today to show that it can be done with regularly usable provider tools. So for more on what happens after I click submit here, I'm going to pass it back.
So we'll start by discussing the back end of our system. As you saw on the center screen, we've just received an EICR and RR from the provider who treated Stella. Several counties in Washington have made fatal and non-fatal overdoses notifiable conditions, which means that we, as the Department of Health, are able to receive case reports. University of Washington and Care Evolution are acting as our health information exchange and interoperability engine. So as you can see here on the center screen, UW has picked up the form data from Epic and transformed it into a format acceptable by Maven. So we're going from that point. But first, we're going to talk about why we do this stuff and why it matters. Education and public alerts are things that we can do as public health. For example, we are able to use our data to notify the public about 2 potent batches of fentanyl that cause many overdose deaths. Here, we're looking at patients with concurrent opioid and sedative prescriptions. By identifying trends, we can prevent disease by focusing resources in areas of most need. Now we're going to talk about how we get the data into the EHR and that into Washington's public health surveillance system. You can see the Maven dashboard on the right-hand screen showing recent patients with events, workflows, and an activity summary. As a public health investigator, we can see it both parsed in Maven as well as in its original rendered form if more information is needed. So here we're looking at information within Maven that we have about the case investigation. EICRs are only intended to be the first report. We need additional information from providers to analyze and classify the case. Providers can supply this information by clicking on the reportability response like you saw. This is much easier for providers than printing and faxing. Here you see labs that were performed, medications, provider notes, and the supplemental questions. Here, Truk is driving around and showing you some of the questions that we're interested in. We're especially interested in risk factors, particularly those that can be targeted by interventions, education, syringe exchange, and behavioral health, certain populations such as pregnant women, and other disease burdens that might pose a risk to the community depending on substance use habits, injectable versus non-injectable hepatitis, for example. So, in conclusion, while providers are focused on individual treatments, population-level monitoring can help by alerting them of local trends. Using prescription monitoring programs, providers can examine prescribing trends. Here on the center screen, we are looking at patients with any opiate prescription, but with breakout by age groups off to the side.
A law was passed in Tennessee making opioid drug overdoses reportable statewide from licensed Tennessee facilities starting in January of 2017, using an electronic reporting mechanism to facilitate investigation, permitting communication back to clinicians involved in the patient's care. Because of this, Stella's report from Mountainside Hospital in Nashville is also reportable to the Tennessee Department of Health, or TDH, and therefore has been routed to TDH from the Ames hub because it met the reporting requirements that were authored in RCKMS. While the Epic EHR system triggered one EICR without manual intervention by the clinician, it met reporting requirements in 2 different jurisdictions, Washington and Tennessee, and was routed accordingly. If you could now direct your attention to the screen on the right. So the EICR is received by the Tennessee Department of Health's Integrated Disease Surveillance System, where through EICR mapping and implementation of workflow decision support logic, the system parses the report and automatically creates an investigation, pre-populated with key information from the report for public health investigators and surveillance staff. Receipt of the clinical information, like history of present illness, details on problems, encounter diagnosis, medications administered, and relevant lab orders, provide public health with more robust information that can aid in confirming cases with less reachback to clinical care. The investigation is also linked to the EICR and is itself within the user interface. So redirecting your attention back to the middle screen. As depicted in TDH's opioid outbreak strategic map, WISE data collection and use is integral to Tennessee's opioid response efforts around prevention through education, regulation and enforcement, and fostering partnerships. Data received from reporting combined with other existing data sources like vital events, death, medical examiners, case management system, hospital discharge, controlled substance monitoring database, and arrest data are used to develop reports and visualizations targeted for specific uses, including targeted infographics on the opioid use in injured workers of Tennessee, heat maps of hospital-reported opioid overdoses or opioid-related arrests by drug type and incident zip codes, publicly available dashboards on opioid overdose deaths, the number of overdose outpatient visits, the number of overdose inpatient stays, and number of painkillers prescribed, or expanding the knowledge base, including a statewide analysis linking PDMP data and mortality data. Tennessee currently collects data on over 100 different reportable conditions, including opioid drug overdoses. TDH understands the burden associated with reporting that this places on clinicians. TDH sees EICR in combination with EICR triggering within the EHR using the information available from RCKMS as an opportunity to not only streamline reporting for all reportable conditions to any jurisdiction, but also for automated reporting, leveraging EHR infrastructure requiring minimal manual intervention by clinicians. In addition, clinical care may now be able to receive automated feedback that provides details on the reportability, links for additional supplemental data capture, and important information pertaining to the event. So now I will turn it over to Ray to discuss another interoperability project surrounding death reporting.
If you're interested in developing population-based data sets for epidemiological research or vital records or development of public policy related to opioids, that process begins with a certification of the death and the filling out of the death certificate. I'm going to briefly explain how using Smart on Fire that can be launched inside an EHR, I can pull data in from an HIE and take advantage of what the EHR already knows about the decedent and try to determine the unambiguous cause of death. You can see here I'm dealing with an 81-year-old man who was previously admitted to the hospital with symptoms of pertussis and influenza. He was released, subsequently readmitted, and died shortly thereafter. You've got his name, his birth date, his age of death, gender, and address. The certifying physician would then fill out the information under the pronouncing tab, and that includes all of the actual information related to the person who's doing the certification. He would then switch to the cause of the death, and the Smart on Fire app is going to look through the EHR and the HIE and start coalescing and aggregating things that might be interesting to these people to figure out exactly what the cause of death was and to try to create a clear and unambiguous cause of death. We can see here the first one on the list is an opioid abuse disorder, so I'm going to choose that. He had a malignant tumor of the colon, and he also had a fractured ankle, all three of which might have led to prescriptions for opioids. Moving on, this wasn't an injury, so we can skip the injury tab. When the physician certifier is done, we go to the review section, and he can review his work, make any changes he wants, and when he's done, he can come to the bottom and click submit or download a fire bundle, which goes directly to our EDRS, and it also generates two kinds of files. One that's going to go to NCHS for ICD-10 cause of death coding, and the other is going to go to any other agency that might want an actual death certificate. So the actual cause of death codes are developed by NCHS, and they're going to be explained by the man who actually does them.
I represent the National Center for Health Statistics and our support of the eVital Standards Initiative, which was created to support the development of interoperability between the jurisdiction's EHR systems and the U.S. Vital Record System. Next. In the scenario we present today, NCHS receives the HL7 death file from Michigan's Department of Public Health through the CDC's Public Health Information Network. Next. NCHS parses the HL7 message to create two output files that include the textual description of the causes of death and the patient's demographic information. The cause of death file is run through our automated cause of death coding system to generate an international classification of a disease-coded cause of death that is sent back to the state in HL7 format for their use. For our part, NCHS analyzes and accumulates death reports for the nation, and analyzed reports and tables are published on our website. Next. We are also working to improve our systems to integrate into the CDC-wide surveillance system to help address the challenges of the opioid misuse. Next. Most specifically, the impact of opioid usage on the overall decline of life expectancy.
So what I would like to speak about briefly is how this will impact us as a state and what this will look like if we were to put this technology into production. Now, the state manages the electronic death registry system, which is the reporting mechanism for our funeral home directors and medical examiners. This technology would allow us to streamline information from the ME case reporting tool and the Health Information Exchange and pull this medical information into the EDRS system. We would also leverage this technology to send information to NCHS and receive ICD-10 codes or coded cause of death information, at which point we will send to our downstream recipients, such as the ones you see on the screen. What is most important to note is that we will be drastically reducing the amount of time it takes for these surveillance systems to receive our death data from months down to just minutes, which is important. So we are most effectively utilizing our data to meet public needs. Collecting data is only as important as how it is used. So this would allow these surveillance systems to identify trends quicker and respond to public needs on a more timely basis, as well as publish usable, up-to-date statistics. Thank you.
So in Utah, we're also working on enabling the FIRE app that was shown by Michigan. And using that, we're hoping that our prescribers, our providers in that state is able to use the app to timely provide information to the health department. So once they do use the app, we do hope that we will get more timely data from NCHS, where we can then send data to our indicator-based system, as you can see here for this use case, where we actually have an indicator that's related to drug overdose and poisoning incidents in the state of Utah. Also in Utah, with death data, like Michigan, we do send it to other divisions within the health department, such as the National Violent Death Reporting System at the health department, but we also use our Department of Health Master Person Index to actually send death notification to Medicare, Medicaid, other health systems, and also to our Division of Professional Licensing. What we also do is that we currently have our several linkage efforts related to this use case, where we are linking our CSD, which is our PDMP, to death, as you can see on the screen, to the cancer registry, APCD, ED, birth, the MVDRS, inpatient, and the MES data. We're hoping that once we do this linkage, then we're able to do advanced analytics related to drug overdoses. Thank you.
So in summary, you've seen two interoperability projects between healthcare and public health systems, electronic case reporting and electronic death reporting. Both facilitate the reduction in burden to providers to accomplish this reporting to public health. Thank you.